So now it's my pleasure to introduce Elisabeth de Vries, oncologist, professor of oncology at Groningen University in the Netherlands, and I think at ESMO one of the very experienced people in the field. I think heavily involved in the RECIST criteria of EU HTA that we all know, and that part of the PFS assessment in any clinical trial, RECIST 2.0, heavily involved in the ESMO magnitude of clinical benefit scale, which, as you all know, is to some extent already existing, let's say, evaluation, comparative evaluation system in the oncology framework, recently published also for the hematology side, and many other working groups at ESMO. Thanks, Elisabeth, for joining, and the floor is yours.
Thank you. Can you hear me? Yeah. Okay, good. So what I will try to illustrate is what ESMO is doing that might support the EU HTA. So we think we have 6 tools and resources to support: the ESMO MCBS, the ESCAT, which is a scale for clinical actionability of molecular targets, an approach to identify bias in studies. We are working on a value-based reimbursement model. We have ESMO clinical practice guidelines, and we have done 2 surveys, and we'll do more in the future. Okay, the first tool, the ESMO MCBS, that started because of disparities in Europe to cancer outcome and access to cancer medicines between and within countries. And then the novel anti-cancer medicines were not sustainable for all European countries, and also not for a lot of countries outside Europe. So therefore, this scale was developed to have a validated and reproducible tool to present clear and unbiased statements and highlight treatments which bring substantial improvements. These are the endpoints used in the scale. Very, very classical, what you would expect. Prognosis of the condition, hazard ratio, long-term survival, response rate, overall survival, progression-free survival, quality of life, and toxicity. There are 5 forms, and we score in 2 settings, namely the curative setting and the non-curative setting. And in the curative setting, an A and a B, and in the non-curative setting, a 5 and a 4 is considered to be substantial benefit. Now, I'm going to show an example, but realize that everything is available on the web, so if you want to perform scoring yourself, you can do so. I would like to illustrate how the scoring is going, for example, with Form 2A, which is in the non-curative setting when a primary endpoint of overall survival is used. And here, the form uses 3 prognostic groups, depending on the median overall survival in the standard treatment. So 12 months or less, between 12 and 24 months, or more than 24 months. And here first you see the form for 12 months or less. And if you look at the grade 4, then it's required to have a 3 months or more gain. And as you would expect, when the control arm is doing better, you need a longer benefit in overall survival, and even more when you go to the longest overall survival benefit in the control arm. Now, here you see grade 1, 2, 3, and 4. 4 is the highest grade which you can get based on these criteria, but as step 2 we check for quality of life, and we check for significant less grade 3, 4 toxicities impacting daily well-being. So that's not a low leukocyte count, it's like continuous headache. If there is less grade 1, if there is a better quality of life or less grade 3, 4 toxicities, then you're allowed to do an upgrade. And moreover, when we see that there is a plateau in the survival curve, you may be allowed to score this drug also in the curative setting. And that's, for example, what we have seen in melanoma with checkpoint inhibitors. So the maximum score here is a 5. ESMO now has scorecards for all the newly approved medicines by FDA and by EMA. And there is also a visual tool included there. ESMO has online tutorials, little movies, text, so if you want, you can practice yourself. What's new? ESMO is currently working on version 2. There will be several adaptations. The last phase of changing the scale is the field testing. And there has just been done extensive field testing, and we will go over that input also in Madrid, and we hope to publish the new version next year. The other two new things is, as you already mentioned, that there's now also a version for hematological malignancies. And we published a paper on how to do quality of life studies and how to report on them. Both papers are published in the Annals of Oncology. And regarding the quality of life, the idea is that in 3 years' time, those rules will be taken into account in order to get an upgrade for quality of life. Potential uses of the scale. We see in these areas that people use the scale. And I would like to dive a little bit deeper into the first two issues, guidelines and public policy. When we look at the guidelines, then so much is changing in oncology. And here you see, for example, tremendous change between 2019 and 2021 for renal cell cancer, that ESMO also has living guidelines to update the data. What is nice that some years ago it was decided that ESMO MCBS would always be reported for the medicine used in the guidelines. So that's what you see here. Everywhere the score of the medicine is added. But what you also see here is that you can't look at one study and how it's scored, because therapies can become obsolete. So basically what we already see since the ESMO MCBS was introduced is that a drug that initially got a 4 or a 5, in 5 years' time can be the control arm for a new medicine that gets a 4 or a 5. So don't see the scoring of ESMO MCBS as standalone. It's closely connected to the interpretation in the guidelines. Now, the WHO uses the scoring to decide whether they will consider medicines for the essential medicine list. And they only accept to consider medicines that score an A or a B or a 4 or a 5. But it's good to realize, for example, if we look at the last round of the Essential Medicine List Committee, that there are medicines that score high, but are not included on the list, and that really has to do with being clinical, meaningful, but unaffordable in most places in the world. Now, about public policy, important issues are to rationalize the use of allocation of resources to help to prioritize treatments with anticipated benefit and to assist HTA decisions. We see that that's happening now in several countries. And we also did with the London School of Economics a comparison regarding HTA decisions in 6 countries and the ESMO MCBS, and in general, you see that the high-scoring medicines are approved and also are faster approved than the lower-scoring medicines. Then about the scale for clinical actionability of molecular targets. That framework helps to rank genomic alterations as targets for cancer precision medicine. And this framework has been published as well. Then we have, as tool 3, an approach to identify bias in studies. And for this, we looked at 3 aspects, from design to to really how the study was executed, like was it a proper control arm, etc. Then the ESMO value-based reimbursement model, that's work in progress. We aim to develop a model to facilitate reimbursement in line with the clinical benefit and local economic realities. This development is done together with the London School of Economics. So clinical benefit of the medicine, adapt to the country, the region level, and here you also see our planned outcome. This is a very challenging task, but we are in the middle of this process and hope that, especially also globally, there will be impact from this framework. Then ESMO has clinical guidelines. I already mentioned you that apart from the regular publication of a new version of the guidelines, we also have living guidelines, so updates connected to the original guidelines to be up to date with new developments in oncology. But all the time, ESMO MCBS will be in there. Then a few words about the 2 surveys that we have done, and that also comes from the fact that we want to have global impact. This, what I show you now, is only regarding the really ordinary medicines on the essential medicine list. And to give you an idea about what does it mean. Here you see the results for cost and availability for high, upper, middle, and low and middle income countries. And it's good to realize that in the list of upper middle income countries, there are European countries. Now you see that here there is the problem, especially in low and low middle income countries. But when we look at the accessibility, you already see that the data are more prominent and more problematic across more countries, and needless to share with you access to all the novel EMA-approved medicines. Then a biomolecular technology survey was done really to check if we need a biomarker in order to be able to treat patients with medicines. Are these biomarkers available, and where are they available? What was obvious from this survey is that large next-generation sequencing panels are largely inaccessible and for clinical routine. That's in general part of clinical trials. Simple validated biomarkers, there the data look much better. There are 2 main barriers, and I think you're all aware of it: financial reimbursement for the test and availability of the test. So ESMO stands ready to help the EU institutions, HTA bodies, and the wider healthcare professional community to implement HTA regulations through the support of its dedicated tools and members' expertise. And this is it.